Hello, my name is Dr. Sanjay Bakshay. I'm a surgeon practicing in Kolkata. I am at present a GC member of the Associations of Surgeons of India. And as you know, the Association of Surgeons of India goes way back to 1937, where in Chennai, very renowned surgeon, that's Dr. Cooper, Dr. Lakshmana Mudaliar, Dr. Joglekar, Dr. Mulgaonkar, Dr. L.M. Banerjee, and Dr. A. Desa sat together, wanted to make an association for surgeons, and it was registered in 1938. The first meeting was held at the King Edward Memorial Hospital, Mumbai. And it was under the mentorship of Dr. Mudaliar and Dr. Venugopal that land was acquired and our headquarters set up. But this is an association which has grown from strength to strength, because it not only is it dedicated to the noble cause of relieving mankind from pain and suffering through sincere and devoted service, it is also integrally involved in training the youngsters so that when they grow up, they can take on the mantle of responsibility. The association strives to take the latest techniques of the surgical field, even the remotest parts of the country. Therefore, this webinar. The motto of the organization is Vem Seva Mahe. We are for service. As you know, this association is dedicated to the noble cause of relieving mankind from pain and suffering through devoted service. But in that process, it also means that we undertake training of our younger surgeons very seriously. Hence, this webinar. The topic that we are going to discuss in this particular webinar is thyroid nodules. We have a major diagnostic conundrum in that some of the thyroid swellings present as a solitary thyroid nodule. And we want to address the topics as what are the common reasons a patient with thyroid disease presents with a solitary nodule. How common is cancer in a solitary nodule? What are the flag signs? What are the signs that we flag out that suggest a cancer? What is the minimum set and sequence of investigation for a thyroid nodule? Is an FNAC, a final aspiration cytology, mandatory? Of course, is an ultrasound mandatory? When we were young, we used to do thyroid scans. It used to be very popular in the past. So when is a thyroid scan done now? What is the need for a thyroid scan? If the biopsy suggests an adenoma, what do we do? An FNAC suggests papillary carcinoma. What do we do? Do we investigate further or rush in directly for surgery? And of course, what is the nature of surgery in cancer of the thyroid? How much do we remove? When do we remove? And what about the node dissection that is required in thyroid surgery? If it is benign, how do we follow it up? Do we follow it up or does it need surgery? What do we do if the nodule is toxic? Because we used to treat these people with surgery, but it seems to me that gradually and inexorably we're moving towards medical and nuclear ablation as a modality of treatment. Of course, the newest advances have to be discussed, and I'm sure Dr. Sarkar will do that. It's the evolving role of neoendoscopic approaches, this one. And of course, the molecular markers in thyroid nodules. So we need to address, we are a country of contrast. So we need to be able to address the cost effectiveness of these molecular markers in India, whether we can treat cancers of the thyroid without them. And to do just that, we have an excellent speaker with us. He's Professor Diptendra Sarkar. He's a professor of surgery and chief of breast surgery and research unit at the ITJMR, Kolkata, India. He was awarded the prestigious GB Ong Award by the Royal College of Surgeons of Edinburgh for securing the highest position FRCS examination in 2000. He is currently the immediate past president of the Association of Breast Surgeons of India and honorary secretary of the Asian Society of Mastology. He is an associate editor of the Indian Journal of Surgery, the organ that ASI uses, and a journal of the Indian Medical Association. He's also an international tutor examiner with the Royal College of Surgeons of Edinburgh. And that association with me goes back quite a distance. He was awarded the prestigious Hawke Visiting Professorship in May 2019 by the Mayo Clinic, Rochester, USA. He's a member of the Working Group Committee on Breast Cancer Screening in India and has been the international resource person for early diagnosis in breast cancer for Bangladesh. He has served as a member of the Governing Council 6 years, steadfastly and unstintingly affording help to ASI during his tenure. His areas of interest include research in prognostic markers and locally advanced breast and thyroid cancer. And he has written more than 40 peer-reviewed articles and contributed to 3 book chapters. Professor Sarkar has delivered more than 200 invited talks. His basic research is on COX-2 receptors, and the role of aspirin has been acclaimed highly internationally. Oncoplasty and locally advanced breast cancer, the major problem in most developing countries, is another area of his interest, and he's working very intensely with that. He's a guide for the PhD and the postdoctorate program with various universities and has been the principal investigator of various projects that are run by the ICMR and the DST. At the All India Medical Conference held conference held recently, he managed to contribute richly to our Association of Surgeons of India, and I think he's just the correct person to contribute richly to this topic, a difficult topic, which sometimes provides a very difficult diagnostic conundrum. Hello.
Good afternoon, members, friends, and if there are postgraduates, to them as well. A warm greetings from Calcutta and from the Association of Surgeons of India. This is an endeavor on the part of the Association of Surgeons of India. And at the outset, I must extend my heartfelt thanks to the association for entrusting me to talk on this topic of thyroid nodules and multinodular goiter. I am thoroughly pleased to have with me my wonderful moderator, Dr. Sanjay Debakshi, who happens to be an executive council member of the Association of Surgeons of India. And though he is a GI surgeon, but I always thought gastrointestinal tract and thyroid are closely related. And I must thank him for introducing the topic and myself. And I am Professor Diptendra Sarkar, who happens to be an ex-executive committee member of the Association of Surgeons of India and a professor with special interest in breast and endocrine surgery at the Institute of Postgraduate Medical Education and Research. And friends, today we are going to discuss on treatment of thyroid nodules and multinodular goiter. And before we begin, let me introduce a few talks and lines from the diary of this great surgeon, Robert Liston, in 1846. He wrote, "It has been proposed again to cut these tumors out. And some surgeons have ventured upon that, but the result has not at all been satisfactory. So necessarily he states that most of the patients of thyroidectomies would die." And 30 years down the lane from Samuel Gross, almost a copy-pasted page from his diary states that can the thyroid gland, when in the state of enlargement, be removed with a reasonable hope of saving the patient? Experience answers an emphatical no. In 1876, however, a major revolution took place. The surgeons of that era were used to operating on various patients with this instrument, which is very known to us, which is called the hemostatic forceps that we use today in the name of Spencer-Wells variety. There was a gentleman who added a small little tip, a tooth at the top, and called it a more robust hemostatic forceps. Ladies and gentlemen, let me introduce the father of thyroid surgery, Theodore Cocker, who innovated this wonderful instrument. Not because of this, but of his profound work on the physiology, pathology, and surgery of the thyroid gland. This father of thyroid surgery was bestowed with nothing but the Nobel Prize in 1909. With the homage to this gentleman, I, Dr. Diptendra Sarkar, would like to have a discussion on treatment of thyroid nodules and multinodular goiter. The core areas that I intend to cover are these 8 different chapters, and viewers, you'll understand as I go through the different chapters, starting from the clinical evaluation and ending at the principles of how thyroidectomy should be done. It covers by and large everything that is related with non-toxic thyroid nodules. To begin with, evolution has been, or an evaluation of a thyroid nodule have been given a nomenclature, quite like that of breast, where we call it triple assessment. We have started calling it as a quadruple assessment, which includes a good history and clinical examination, a thyroid function test, a radiology, which includes an array of, or rather a spectrum of different techniques and technologies, and finally an aspiration cytology to stamp a diagnosis and then proceed. Now, coming to the core area 1, which deals with the clinical evaluation and the history, it has got 5 steps. Step 1 is to evaluate the history when it started and how it proceeded. Now, if there are postgraduate residents, you need to understand that quite often during the exam, you're going to get a case where the gentleman or your patient has got subtle eye signs, but you palpate the pulse and there is nothing. It is very important that you evaluate the history of the medicine that this gentleman was taking, because that might be the reason why, in spite of certain signs, the major signs of toxicosis are missing. The second step would be to look at the compressive features, and we have 2 tubes, the esophagus and the trachea, 2 nerves, that is the superior laryngeal nerve, the recurrent laryngeal nerves, and 2 vessels, the jugular as well as the carotid, and the history of compression needs to be included. Step 3 would be to look at the features of hyperthyroidism, and in this we have 3 different pillars. One is the general features of toxicity, which includes heat intolerance, weight loss, increased appetite, yet diarrhea, palpitation, and also the neurological symptoms. And in females, you must understand there is an inverse relationship, that is, in ladies who have hypothyroidism, they are likely to have menorrhagia, and ladies who have hyperthyroidism are likely to have oligomenorrhea. The second pillar is the eye symptoms, which you all know, starting from protrusion of the eyeball to dual vision and finally to loss of vision because of prolonged exposure keratitis. There is a unique feature in hyperthyroidism that's called thyroid dermopathy, and that's a feature which it shares with its counterpart hypothyroidism, where the shin bones tend to get more thickened, there is extra hair fall, and there are brittle nails. Coming to the step 4 would be that if you suspect that this is a thyroid cancer, you must exclude the symptoms which are related to metastasis. And you happen to suspect that it can be a medullary thyroid cancer. Do remember that many of them might have features of hypercalcemia as well as fluctuating or prolonged hypertension suggestive of pheochromocytoma. That has to be taken into the history. And finally, the duration of treatment. The family history is equally important because, as I said, most of the medullary thyroid cancers, at least 25% of them, has got a familial linkage. Again, if this lady or the gentleman is coming from an area where it is endemic to have goiters, so the history of the family as well as the community has to be taken. And we have already discussed about the treatment history, so not going into the details of that. The 5 pillars of evaluation begins with proving that this is a thyroid swelling, that is a swelling which is butterfly in shape, moving up and down with deglutition, is likely to be a thyroid swelling. You ask a lady who has got a very small swelling, very of confusions, whether it could be a thyroglossal cyst, to ask for a protrusion of tongue. And if it does move, it's a thyroglossal cyst. And if it doesn't, then it's a thyroid swelling. The second part is to look at the character, whether it's a multinodular or a solitary thyroid nodule. And for that, one can use the thumb on different aspects to use it for the Kreil's technique to find the multinodularity of the thyroid swelling. The third part deals with the symptoms or signs rather of compression, and the fourth part that of the features of toxicosis. And finally, the fifth pillar is if you suspect metastasis, one has to search for in terms of looking at bony tenderness as well as lymphadenopathy in different aspects of the neck. Coming to the second core area, which is about the thyroid function test, which comprises the second part of the quadruple assessment in thyroid, we usually start with a baseline TSH, and that's good enough in most of the cases. However, if we do find clinically there are suspicion of having some sort of occult thyrotoxicosis, we might choose to have a free thyroxine estimation to see whether there is any evidence of hyperthyroidism. We would also like to have an estimation of destructive antibodies. That means anti-TPO and thyroglobulin antibodies, because quite often if somebody has this, it might put us on a false negativity while we are treating these patients after the surgery. This is the neo definition which came in hyperthyroidism in the last 3 to 4 years. That's an update as well, that primary hyperthyroidism means hyperthyroidism arising from the thyroid, and it's a reduced TSH with elevated thyroid hormone levels, whereas secondary is a cause mostly in the pituitary or in the hypothalamus or in an ectopic thyroid tissue. In them, there is both elevated TSH and elevated FT3 and FT4. Now coming to the third core area, that's the imaging, and probably this is one zone where imaging has put its strong footsteps in terms of turning a subjectivity into strong objective reasons to believe whether it's a benign or a malignant lesion. These are the classical signs which we expect. Now, this is one of the patients with a CT scan. I took the CT scan for the viewers to understand how it looks like. If the lesion appears to be complex with hypoechogenicity, if we find that it's a taller than it's a wider lesion, and there are evidences of small little microcalcification here and there, then you suspect that this could be a malignant lesion. Now, if you add some sort of a thyroid ultrasound and a Doppler to that, now this is what you see. Now, if this is a Doppler, you will suddenly start picking up small little vascular dots within the thyroid tissue. And if you have those small little vascular dots, and if you find that during the diastolic phase, there is intense residual vascularity within the thyroid, you suspect it to be either an inflammation or a malignancy. However, if the arborization is completely random, then it's likely to be malignant, whereas it is likely to be more smooth, then you think it's a benign inflammatory lesion. The next important thing for all postgraduates to understand is the characterization of a metastatic node. Now, viewers, you look at this very carefully at this small bean-shaped node. Now, the nodal architecture means there will be a capsule and a subcapsular space and a hilum quite like this. And when there are cancers, the cancers tend to come down from above and put its deposit in the subcapsular space or somewhere in the subcapsular space beneath as well. Or it can go into the hilum through the hilar opening. What necessarily happens once the hilum as well as the subcortical space is blocked, it tends to change its shape to the globular form that you see here with the loss of hilar fat. And therefore, the transverse diameter also expands. It is said the average transverse diameter more than 7 millimeter is suggestive of a metastatic node in the neck. Now, this is a classical example that you see here. This is one of the gentlemen with a flattened node, and this is one of the gentlemen with a metastatic node. Look at the two characters. This is flat and this is globular, which is suggestive of metastasis. We normally would not do a CT or an MRI unless, of course, we are not clinically and ultrasound-wise unable to understand what is the extent of the lesion, and then we would opt for a CT or an MR. Coming to the nuclear medicine and its use in diagnostic, well, the initial boom of using nuclear medicine for diagnosis has really taken a small nosedive, though its scope has been improving in therapeutics, but in terms of diagnosis it is going down. And if we are not stamping it as a case of hyperthyroidism, and we are not very sure whether the nodule that we see in this hyperfunctioning state is the nodule which is generating more thyroxine, or the rest of the gland is doing that, we would normally not do a nuclear thyroid imaging for most of the non-toxic or malignant lesions. But one must remember only a small percentage, less than 5% of the hot nodules might harbor small focus of malignancy. We have at the institute at IPGMRF Calcutta operated more than 600 plus thyroidectomies in last 10 years, and we do not happen to find a single case where we could detect hyperthyroidism with a focus of malignancy. There are objective ways, as I said, of assessing, and that's called the TIDAD system. This is a very robust system where we have summation points by which you can tell what is the character. There are thyroids of TIDAD 1, 2, 3, 4, 5, and based on the summation point, we can tell whether it is benign, it's not suspicious, it's mildly suspicious, it is moderately suspicious or highly suspicious, and can even recommend at which size we'd go for a fine needle aspiration cytology. Now, coming to the fourth chapter out of the 8 that we are going to discuss today, we are again going into something very objective that has come in thyroid, which is called the cytology. And again, there is a controversy that whether you should go for a blind FNA from a nodule or you should choose ultrasound guided FNA. Now, thyroid is one gland where you find a nodule, make it mandatory to use your radiological friends to go for an ultrasound guided FNA, because quite often you get a complex nodule where there is a harbor of malignancy in the solid part. So you need to hinge your needle into the solid component and not the cystic component. And therefore an ultrasound guided FNA is going to improve your diagnostic yield. And this is the classification that have come up, which is known as the Bethesda classification, quite often being used in most centers. Now look carefully, it's the score 3 and 4 that remains the gray zone. And we will discuss how these gray zone issues of RTPR of undetermined significance or follicular lesions of undetermined significance, or for that matter, follicular neoplasms, where we have diagnostic confusions, we can use other tools to diagnose it. We come to the next one, the newborn baby, which started walking say around a decades back. We call it molecular signatures. Can that be a crisis manager for indeterminate lesions? The first publication in the Journal of Endocrinology and Metabolism in 2009 and 10 give this statement that recently it has been reported that by molecular testing for thyroid nodules, which includes the RAF, RAS rate, and the PAX8, the presence of any mutation was a strong indicator of cancer, because 97% of mutation positive nodules had malignancy at the time of histological evaluation. So therefore the molecular signatures do have a major role in increasing the diagnostic yield, and RAT, RAF, RAS, TART, and PAX8 are a very important tool in diagnosis. On the other hand, if you look as in terms of prognosis, the VGF, the TART and the histone does play a role, and in some studies, RAT also have been rated as an important tool for prognosis. But by and large, it's mostly in terms of diagnosis that it has been helping. Look carefully as they done. at this curve. Now, if we normally use quadruple evaluation as our tool, the total diagnostic accuracy or the specificity will reach to around 60 to 70%. But if we add molecular diagnostic tools, there is a jump in almost 30% in terms of diagnosing an indeterminate lesion to stamping what the diagnosis is before we start a treatment or a surgery. And that has actually reduced the number of redo or revision surgeries after a lobectomy biopsy. Coming to the sixth end, which is possibly the most interesting zones and the most debatable zone, is the principles of treatment in non-toxic thyroid nodules. I have intentionally kept the thyroid nodules, which are toxic, because that's an area of a bigger area where we need to take into consideration the other non-surgical modes. So as surgeons, we would like to discuss more on the non-toxic thyroid nodules here. Now, I would, for the purpose of postgraduate residents, put the indications of surgery in non-toxic thyroid swellings as 3 C's. Number 1 is compression, number 2 is cosmesis, and number 3 is cancer. So if you have any of these 3 C's, that is an indication for surgery. This is the traditional types of thyroid neoplasm. I'm not going to the details of the subtypes. Coming to the hotly debated topic called differentiated thyroid cancers. I continuously go on putting it as, defining it as different types of controversies. That's what DTC is. If you look at these big cancers, we do not have any controversy whatsoever. You are going to take out, and you might end up in doing a composite resection, taking out part of trachea and repairing it. But lesions which are very small, the question that comes is, are we overtreating them? And therefore, the question comes, why in DTC the question of overtreatment comes so strongly? Because differentiated thyroid cancers are peculiar cancers. They look like the same old thyroid cells which the individual is harboring, yet their proliferative index have gone up. So physiologically and pathologically, many of them behave almost the same, yet they're metastatic and the proliferative potential is high. And that makes it a very debatable situation, to what extent you should be treating them. The controversies are there on thyroidectomies, to what extent, ablative therapies, is it effective, and finally suppressive therapies, to what dosage you must be upscaling so that the gentleman has got a good response. Unfortunately, there is no major level 1 randomized prospective trial. The reason is the disease itself is not so common, and with the outcome where we speak on 20-year survival with 98%, to have 2 arms, one which is showing a 20-year survival without a particular form of treatment, to other which is having it, and coming with the statistical significance is very tough. So most of the data that we have are level 2 evidences and level 3 evidences, and that comes from a cohort of retrospective studies and meta-analysis of them. But we do not really have a level 1 evidence. So in surgery in differential thyroid cancers, we did have multiple debates, and I hope most of the viewers will agree that those debates have been taking place in your hospitals, in conferences for the last decade. And there are advocates of total thyroidectomy who would argue that you remove everything, you remove the multicentricity of the tumor, you give the patient a better scope for ablation, and you give the patient a better scope for follow-up. Whereas a minority, particularly the British school, has been arguing very tough against the US school in the last decade, that if somebody has a 7mm lesion, putting the patient to a total thyroidectomy and increasing the risk of parathyroid removal or an RLN injury is too much for a disease which is likely to have a 99% cure. But if you look at the verdict, now the last evidences that comes clearly states that if the size of the lesion is more than 1 centimeter, the recurrence and the death rate is significantly higher in the conservative arm. And the p-value, if you look, is 0.04. That's a robust evidence to suggest, though from the retrospective data, but it's a robust enough evidence to suggest that one should be offering these gentlemen with total thyroidectomies if the size of the lesion is more than 1 centimeter. Now, as such, if you look at my lymph nodes, as such, the lymph nodes, if there are micrometastases, it doesn't alter the survival. So we do have a conservative approach unless there are big metastatic nodes and there are pericapsular spread. Most of the circumstances, we go for a conservative prophylactic neck dissection in the central zone. However, if there are metastatic nodes, we can choose to have anterolateral to a central nodal dissection, and only in certain cases where there is extensive lymphadenectomy, a standard MRND is advocated. And as I said, in most of the circumstances, your data or your evidence whether the lymph node is metastatic or not comes from your pre-op ultrasound or a CT scan, and therefore looking and the ability to understand the characters of a metastatic node does play a very important role. Coming to the 7th zone, how much does the adjuvants help us? Now, of course, my colleagues who are nuclear physicians will start arguing that there is a huge scope. You can remove almost everything, even the small one cell that is left behind after a thyroidectomy. You remove the occult microscopic foci and you can treat an unknown or unknown amount of residual tissue. But as surgeons, what we must believe, and I have seen this happening with many postgraduate residents and young consultants who believe that this sort of thing, that radioiodine will get whatever we miss. And therefore, you initially planned a near total thyroidectomy and you end up in subtotal thyroidectomy. But believe me, it doesn't work in that way. Your effort should be for a total thyroidectomy. You might end up leaving behind less than 5%. Then only the ablation works, or else you have to go for a redo if it's more than 10% residue. The time of ablation is you make the patient intentionally hypothyroid for 4 to 6 weeks after the surgery, go for the radioiodine uptake scan, and if you find there is a residue, which is just a small amount between 1 to 5%, then you have to go in and go for an ablation. In certain circumstances where there are enough evidences of gross hypothyroidism in terms of TSH more than 100, and if you find the presence of the residue is less than 0.1%, and there is nothing abnormal seen on a CT or an ultrasound in the neck, you can spare. Or else, if a lady is pregnant or a lady is breastfeeding, or in somebody where you are contemplating that if you use a dose which is very high, is likely to produce a bone marrow depression, then you should be avoiding it. Now, the other area you see is a pulmonary restrict. Now, somebody look at a gentleman who has got a COPD and has got intense bilateral lung mets. Now, if you use high dose ablation in them, there may be huge lung fibrosis and the COPD might go into a failure. So that's one of the gray zones where you should be more restrictive. Similarly with salivary gland function, hypofunctioning, which can lead to xerostomia. And if you have an unstable fracture, it can really become a compression after you used a huge or heavy dose of ablation. Normally, if it's a small lesion and you have no extrathyroidal spread, no lymph nodal spread, we would restrict to a low dose ablation, which is between 50 to 125. Though there are certain evidences which suggest a dosage less than 30, but most of my nuclear physician friends would not resort to using less than 30 MCI for an therapeutic ablation dose. If it is a more aggressive local disease, you are going to definitely increase the dose to 150 MCI, or if there are lymph node mets, there are soft tissue residuals, there are distant mets, the dose escalation goes. And therefore, we leave it to the nuclear physicians to choose an appropriate dose depending on the amount of residue. What are the prognostic and risk factors? The traditional ones that we know are age, metastasis, extrathyroidal spread, size, lymph node, and certain new molecular markers, of which a very important one is VEGF. They have come up very strongly. And based on that, there had been traditional ones like risk classification system, of which the third one, which is coming in a yellow font, the masses, is the most favorite one that we use in our daily clinical practice. Now, this is a very complex formula, and naturally, most of you who are young consultants would like to feel that this is such a complex formula. If you have a smartphone in front of you, something like that, you just jot in a masses calculator, and the masses calculator automatically comes in, put in the data of age, the tumor size, the completeness of resection, the local invasion, and distant metastasis. It calculates and tells you what is the score and how much would be required in terms of adjuvant therapy. Now, there are other risk stratification models which are suggested by the American Thyroid Association. It does help in risk stratification, and survival improves if somebody has got a low risk disease. But this is the model that we tend to follow at our institute. If it's a really low risk, that's the masses is less than 6, we would resort to thyroxine supplementation only. If it is an intermediate lesion or a high-risk lesion, something like this, in that circumstances, an iodine ablation of the residual thyroid is done. And after that, you can choose to use a supraphysiological or a supraphysiological dosage of thyroxine. Of course, the yellow and the blue zones comes with a pinch of salt. The gentleman or the lady in whom you are going to use it, you must be very careful that they don't have a gross cardiac comorbidity that might pose some problem because of the intense tachycardia. And in some, the compliance becomes an issue. So most of us would resort to a physiological supplementation or just a supraphysiological supplementation after an ablation is being done. So to sum up, in DTC, we have the option of surgery, and at present, the evidence is strongly in favor of total thyroidectomy unless the tumor size is less than 1 centimeter. Radioiodine ablation, we don't have a consensus, but you can spare a patient of radioiodine ablation if the size or the risk, the category is low risk, really low, less than 6. Thyroid function, the thyroid suppression therapy, we would resort mostly to physiological and supraphysiological. External beam radiation is kept only for palliation and recurrence. These are the follow-up schedules. Now, once you start following up these patients and you have a raised thyroglobulin level, you are going to ask for a radioiodine uptake scan. In 75% of the cases, the scan is likely to show iodine uptake. But in 25% of the cases, it might so happen that the TG is elevated, but yet there is no uptake. Now, this is a borrowed case from the net where this is a classical example where the thyroglobulin is elevated. The I31 is negative, but the PET is positive. No guesses for prizes, but this is a classical example where what has happened is that the cancer from a differentiated form is going into an anaplastic form and therefore is losing its capacity to uptake iodine. And in such cases, what we choose to use is called a redifferentiation therapy. Going back to the slides, these are our options at present. Some molecular targets, and you can use the PAX8 PPAR agonists and retinoid therapy. And once you start using them, again, it becomes differentiated to a radioiodine uptake sensitive tumor, and then you can use a radioiodine ablation therapy in them. However, there will be patients in whom it doesn't work, and in them you have these choices. The first choice, as I said, would be a molecular target. Now, this trial, which is known as the decision trial using sorafenib, has conclusively put after the end of the phase 3 that there is almost 7 months progression-free survival. The overall survival as of now doesn't seem to be very conclusive. The toxicity is a major issue, but in terms of progression-free survival, there's a 7 months advantage. The second trial, which is known as the SELECT trial, where you use lenvatinib, which is yet another molecular target, has shown a more optimistic results in terms of a 15-month survival advantage, though of course the overall survival remains the same. The toxicity profile goes up by 70%, but in terms of progression-free survival, this is a big leap. Those patients where the therapy still is non-responsive, you can choose to use an external beam radiation, though with not much effect except a better palliation. And in short burst of chemotherapy, as I said, the response again is of short duration and not very predictable in most of the circumstances. We have good news for the next generation, and we do have good news for many of the thyroid cancer patients as well. As I said, we are going to use molecular targets once we find that they are iodine-resistant cancers. But even if we use this, what happens after around 6 to 10 months, there will be an escape phenomenon. And once you escape, once again, the disease starts progressing. And in them, we can use lapatinib and dabrafenib, which are HER2 and HER3 antagonists. And so what they can do is, once again, they can stop the progression of the disease. If it fails, you go to the next level and you use another molecular target, which is an ALK translocation modifier. And again, a 3 to 6 month survival advantage can begin. And finally, if it doesn't work, then we have this wonderful mTOR pathway, because most of the cancers will work to the MAP kinase pathway. If suddenly it gets mutated, you can get mutation modifiers in terms of mTOR pathway modifiers, which has got excellent results in breast. And at present, the initial results in thyroid also is wonderful, and everolimus does work as a magic medicine in many of the patients. Coming to medullary thyroid cancers, again, it would be extensive to discuss the whole things, and one must understand this is a variety where 25% are hereditary, and most of the hereditary are bilateral, and it has got an inbuilt genetic linkage called the red proto-oncogene. They are linked with the MEN syndrome, and therefore these individuals are prone to develop pheochromocytomas and parathyroid hyperplasias and adenomas. Calcitonin is a good marker, and quadruple evaluation remains the mainstay. And this is the prognostic markers: younger age, the extent of involvement, the lymph node involvement, and whether you could take out the whole thing or not remains the 4 pillars by which you can prognosticate an MTC. As we have discussed, most of the MTC we do find with surgery and occasionally with external beam radiation. But the major advancement has been the use of molecular targets. And these 2 molecular targets, if you look at vendatinib and carbozamatinib, you will find that both of them are having a wonderful survival advantage. Whereas the first oral tyrosine kinase modifier, which also modifies the VEGF and EGFR receptors, does have almost 12-month survival advantage. That's again a big leap in terms of survival of the patient. And it does help, and it's almost at the end of the phase 3 trial, and that is going to be a path-breaking methodology to be used in non-responsive and progressive medullary thyroid cancers. Coming to the last core area, which we call the principles of thyroidectomy. Now, when I started my career and I was into my first phase of observing and assisting one of my boss, he told me, "Sonny, you should not be trying to find out the recurrent laryngeal nerve. And if you do so, I'm sure you are going to injure it." And I believed as a young intern and an initial house jobship that it should not be searched. And later on, I did find that unplanned searches do actually end up in injuring the recurrent nerve. But the consensus is very clear. It's written on the walls. Follow the standard guidelines, and you must be able to delineate the nerve while you're doing a thyroidectomy. Going to the upper pool, there are various variations. Some of the nerves, the superior laryngeal nerve might come very close with the superior thyroid pedicle, and some of them might almost go into the gland. The tricks remained is that the vessels has to be identified separately. A small little dissection has to be done on the medial aspect of the thyroid. You must be able to identify the nerve and preserve it. And the age-old sayings that ligate it close or on the gland should not be done, because if you do so, in most of the circumstances, in the post-op uptake scan, we find a large residue kept in the upper pool of the thyroid. This is a classical picture of a recurrent laryngeal nerve, though of course in 1% of the cases, if you're really in your bad day or a bad hour of your clinical practice that day, you might find 1% of patients who have a non-recurrent branch. In my clinical practice, I have got 3, and in one of them, I must confess that I did end up in injuring the recurrent laryngeal nerve of a young lady. So one has to be really very careful in terms of identifying the white structure that tend to go and cross the thyroid. Now, William Halsted, everybody knows this gentleman as the father of breast surgery, which is also one of my closest discipline to my heart. But the reason I've kept his picture is he gives a wonderful analogy or a comparison between 2 surgeons, which sums up the basics of thyroid surgery. Now, he writes that I had pondered this question for many years and conclude that the explanation probably lies in the operative methods of 2 illustrious surgeons. Cocker was neat and precise, operating in a relatively bloodless manner, scrupulously removed the entire thyroid gland, done little damage to anything outside the capsule. Whereas Billroth, who was supposedly the more heroic one, operated more rapidly and, as I recall his manner, with less regard for tissue and less concern for hemorrhage, might easily have removed the parathyroids or at least have interfered with his blood supply and have left remnants of the thyroid gland. So it sums up that you have to be extremely careful. You have to be working on a bloodless film. And then you are going to be a wonderful thyroid surgeon like as I said, Cocker, or you end up in a fantastic GI surgeon like Billroth, but not that good thyroid surgeon as William Halsted has mentioned in his diary. Now, this is the standard guideline for RLN and the parathyroid. Now, this is the thyroid, and this is how the RLN will go, and this is the thymus and the thyrothalamic tract. Just on the junction of this, you're going to get the parathyroid. If you put it on a picture like this, this is how it looks. From beneath, you are going to have the inferior thyroid artery coming up, pierces the parathyroid, and goes up to supply the thyroid gland. So if you do a capsular dissection and then the thyroid supply is gone, you reduce the chance of recurrent laryngeal nerve injury and you reduce the chance of parathyroid ischemia. This is where we usually search. Again, for beginners, we urge that the search should be done just after the nerve exits from the thorax and goes up. And if you start searching it here and trace the whole nerve, you will be able to delineate the nerve very thoroughly, something like this. So the take-home message is the quadruple assessment is key to evaluation of thyroid nodules. So all patients must mandatorily, like in breast, must have a quadruple assessment. Of course, if you think that it's a malignancy, you can have a lesser amount of thyroid function tests. If you find that it's a toxicosis, you can omit FNA, but these are your cafeteria choice. Molecular signatures improves diagnosis of indeterminate neoplasms. As I said, 30% leap in terms of diagnosis, where we had been doing multiple redo surgeries, going down because of the molecular signatures. Near total thyroidectomy is the standard of care if the lesion is more than 1 centimeter in size. So no arguments, no debates in terms of thyroid preservation if the size is more than 1 centimeter. Capsular dissection with nerve delineation is the most accepted technique. Again, as I said, my wonderful boss, who has given me many good surgery training, I must confess, was wrong in telling me that do not try to search the nerve. So you must delineate the nerve the whole length and do a thyroid surgery. Radioiodine ablation improves the progression-free survival, but the evidence is only in high-risk lesions. In low-risk lesion, it's a free zone, and if you want to, you can skip a radioiodine ablation. Supraphysiological dose suppression requires a good patient compliance mentally as well as physically. As I said, if the patient has got cardiac comorbidity, try to avoid it. Finally, molecular targets is the biggest boon, not only in thyroid, but in all cancers. And they have been able to improve the progression-free survival on an average between 5 to 14 months. And they are to be used. And we are sure, though the cost is a challenge and toxicity is a challenge at present, but I'm sure in this coming decade, you are going to see more and more of molecular signatures and their targets being used in thyroid cancers. So the moral of the story, ladies and gentlemen, is look at these two gentlemen. I hope you are able to understand and identify both of them. This is, I suppose, if I recollect, that's from Amar Prem, and that's Rajesh Khanna, the big don of film industry in the 1970s. And this is the angry young man of Bollywood, Amitabh Bachchan. And when we go on almost 25 years down the lane, the gentleman above refused to change. And though we have our full respect to this gentleman, because he refused to change, he went into an oblivion in his final days and left for the heavenly abode sometime in the last decade. But this gentleman, every day I see, he is an inspiration in the sense that he has changed every day and therefore has continued to rule the world of industry today. And ladies and gentlemen, friends, students, and whoever is observing this webinar today must understand change is the rule of the universe, and change is something which improves our techniques, and change is something which gives us better survival, and therefore change for the best and for the better. Thank you very much. I have with me Dr. Sanjay Debakshi, who will take your questions. Please do start sending us immediately the question that you have in your WhatsApp. I'm here till 5 o'clock to answer any question related to thyroid. And as I said, we are going to discuss the next webinar at the end of this whole program. And again, I must extend my heartfelt thanks to Association of Surgeons of India. So here we are sitting for you and waiting for you for your questions. Please do start bombarding us. Thank you. It's over to Mr. Debakshi. You can start the questions now.
Okay, thank you very much. There's another question. What is to be done when an operated case of DTC on follow-up, the thyroglobulin is elevated, but there is no evidence of residual or metastatic disease on imaging? You've addressed this topic, but I think it might just bear repeating.
Yeah, that's a very intriguing scenario. Actually, you do find in around 25% of patients where the differentiated thyroid cancer has actually become de-differentiated. Now, I forgot the name of the gentleman who asked the question. Now, what is the
Dr. Devashish Naik.
Okay, Dr. Naik. So what happens? Normally a differentiated thyroid cancer is one which remains its physiological function and capacity. So it would be imbibing and drinking iodine normally. And therefore, you normally, if you do a radioiodine uptake scan, it would be taking up the iodine. But if it goes to a traditional cancer where it becomes more dedifferentiated, it won't be able to accept iodine. So in these cases, if you do a PET CT, it will follow the rules of taking more glucose, and they are going to show it as PET positive. So this is the ideal scenario where it is TG raised, the thyroglobulin is down, I mean the uptake scan shows nothing, and the PET CT is elevated. And in these cases, you can use retinoic acids as a dedifferentiation therapies. You can choose to use certain targets as well and PARP inhibitors as well. And once you use them, once again they go back to its redifferentiated form, and that's called a redifferentiation therapy. And then you can use ablative therapies. Even if it is not becoming sensitive, as I was telling in my talk, that you can choose to use some of the molecular targets with excellent results, with a survival going up to almost 1.5 years in certain cases.
There's a Dr. Ankit Goel with Diptendra who has asked, do we need to do a prophylactic central node dissection even in node negative papillary thyroid cancer?
Yeah, as I said, there is no robust level 1 evidence, but those who routinely perform thyroid surgery, we would recommend doing a prophylactic central nodal dissection. It does not contribute to extra morbidity. Of course, the implication is if you find the microscopic mets, what is the next? As of now, the evidence suggests that micrometastasis does not alter the prognosis. But again, dissection of the Delphian nodes in the central compartment is what we normally recommend those who are routinely doing thyroid surgery.
We have a Dr. Chandusagar Neelakantham from the S. Sarkar Savera Hospital in Patna. And he asks, what is the risk category of the nodule in the ectopic thyroid tissue?
What
risk category?
Risk category? Oh, risk categorization of
nodules in thyroglossal duct and ectopic thyroid tissue.
Okay, as I said, there should not be any extra or different risk categorization. While you are doing a thyroid surgery, I mean for a thyroid cancer, if you dissect the isthmus and you do the routine central nodal dissection, you trace if there is a levator glanduli thyroidi which is going up into the foramen cecum. You have to trace them and excise it. Quite very rarely you might get a carcinoma in the thyroglossal cyst as well, and in those circumstances the risk categorization normally doesn't change. It remains the same as it is for any other differentiated thyroid cancer. Only issue is getting it all on a sudden might put in some twitches in your brain or any place, but as I said, as a rule the risk categorization doesn't change.
He also has another question, Diptendra.
Yeah.
What causes mortality and morbidity in patients with goiter? A generic question.
Okay, I mean the biggest issue is compression, and as I said, in compression, we have had hugely neglected patients who would come with a stridor, and in them, it can be a life-saving emergency. I mean, dealing with these patients with huge goiter can be very dangerous, and you initially had to intubate if you find those patients in stridor, or else you can go for a tracheostomy, which is at times very difficult if the size is very big. The second issue I have seen in patients having presenting in clinics is they were standing with a huge thyroid swelling, and somebody called from the back. He turned around, and with this twist and the turn, there was a compression of the carotid. He just went into a syncopal attack. So such cases where huge thyroid swelling, which can suddenly accidentally block the carotids, leading to syncopal attacks, can also be dangerous. And of course, the compression of the jugular veins can lead to huge puffiness. But as I said, the immediate cause of mortality could be tracheal compression. And during the surgeries, in certain situations, we do find that it pulls the trachea, and once the trachea is out, it collapses. And quite often, it might so happen that the trachea and the esophagus, we normally tend to think it's going to be like this, but because of the pull, the esophagus can come out from behind. As a result of which, during surgery, you can take out a chunk of esophagus if you are not doing it with the proper care. And therefore, these are the common compressive features, are the main reasons for benign goiters to come to us with life-saving emergencies.
In effect, there's no compromise to careful surgery.
Yeah, there is no compromise, exactly.
We have a Dr. Avdesh Manoharlal Ramanuj who has a clinical problem. He says, one of my patients had bilateral multinodular goiter and a near total thyroidectomy was done. Pre-op all investigations were suggestive of a benign lesion, but HPE showed follicular carcinoma. The RI study was from radioiodine study was performed after 6 weeks, showed more than 2 lesion. Patient surgery was also done. Post-op HPE showed no signs of malignant tissue, but still after 6 weeks, almost similar area of radioiodine uptake is still there. What would be the further course?
Okay. Yeah, that is not a very uncommon situation. I mean, number one, that you do a thyroidectomy and you incidentally come out with a microscopic or a macroscopic focus of malignancy. That is absolutely not an uncommon situation. And what you need to do, you go according to the standard practicing guideline, you go for an uptake scan. And if you find there is a major part of the nodule left behind, then you need to go back and do a revision surgery. And if it's a microscopic residue, you need to continue with radioiodine ablation. Having said that, we do get patients in whom an uptake scan shows extremely small residues. And, and quite often, my endocrinologist friend would send back the patient asking me that, can you do a surgery? But in these circumstances, you need to check it with a CT scan. And even CT scan, you can demonstrate small areas of residue. Then only it is advisable to go in. Or else, going in without knowing where exactly is the residue can be quite catastrophic. I would rather ask you that if there are evidences of microscopic residue, you continue with ablation therapies. Don't go in unless you are very sure which area has to be taken out. I have seen my friends coming up with recurrent laryngeal nerve injuries because they were over enthusiastic about going in, not knowing where the enemy is. So yes, if you find a residue and you cross-check with a good CT scan to find that where exactly is the residue, then it's accepted to go in, or else it will be a safe practice to continue with ablation therapies.
Diptendra, I'm just borrowing something from my GI surgery. Post-radio ablation, what would you find more appropriate, a CT scan or MR?
Both are good. MR is fantastic, but the only issue is if you have a well delineated area, then I would prefer an MR in the sense that they would be able to locate the invasion and the anatomy better. But if you are going into an unknown zone, I think possibly CT is something marginally better. Of course, both have its own advantages and disadvantages, and it is left to the radiologist of the institute. If he's more keen on doing a good MR, then it's an MR, and those who want a CT as a traditional technique, they would prefer that. But as I said, if it's a soft tissue and you want to have a better delineation, established localization, MR will be a good choice.
Perfect. There's also Dr. Amit Kumar who has said that he has had an FNAC of a colloid nodule. The ultrasound showed a solitary nodule. He went ahead and did a hemithyroidectomy, but it, unfortunately, as it so frequently happens, it was a malignant follicular carcinoma. So what would you say?
Yeah, as I said, if you go back to the Bethesda classification in cytology, number one, Dr. Amit, I would recommend, even if it's a follicular carcinoma, your FNA may be very low, as close to 25%. But the dictum is you should not be doing a blind fine needle aspiration cytology. If you have a nodule, always it's a safe practice to go for an ultrasound guided FNA, because in that way you know exactly the suspicious area from where you are taking out. This is number 1 point. Number 2, if you use molecular signatures in cases where the fine needle aspiration cytology shows that it is an indeterminate unknown significance or a follicular neoplasms, there is a 30% improved diagnostic advantage by using the red, or you can use the RAS or the RAF or the TAR, and they are going to give a 30% advantage in terms of diagnostic yield. The third important thing which I would suggest if you want to reduce your redo surgery is if you find a lesion which is more than 4 centimeter, you can straightforward go ahead with a total thyroidectomy, explaining the patients. The only agenda that was contradicting doing a total thyroidectomy upfront was the experience and the technological perfection of the surgeon. If the surgeon is doing surgery in a high volume center, there is no harm in going ahead with going for a total thyroidectomy. It's just an 80 paisa capsule that the patient requires. If you are doing it regularly and have an acceptably low incidence of RLN or parathyroid ischemia, then it's fine to go ahead with total thyroidectomies for a larger lesions more than 4 centimeters. I hope that answers the question.
That's a great lesson, Dr. Diptendra, because a large part of India won't have access to molecular signatures. So I suppose that what you ended up with was a very important message, a very important lesson for youngsters across India. We have a Dr. Ashit Chakraborty who has said, what are the high-risk criteria in solitary thyroid nodules? Dr. Ashit Chakraborty.
Okay. So number 1, a heterogeneous lesion is characteristic, or there is high suspicion of malignancy. Number 2, a clear-cut cystic hypoechoic lesion is a cyst, so you should not be bothered. A clear nodule is also a nodule, you should not be bothered. But if you find a heterogeneity in the lesion, that's one when we start suspecting that can be a cancer. Now, if you add a Doppler to that, immediately, normally you find that it's a benign nodule, you are not going to see any intralesional vascularity. But if you add a Doppler and you start getting small little intravascular dots, and the character of the vasculature is irregular, then you start suspecting this is malignancy. In certain thyroiditis also you can get intralesional vascular pattern, but they are not so arborized pattern. They follow a smooth pattern of vascularity. But if the vascular network is completely bizarre, then you start thinking that this could be a cancer. So this is number 3. Number 4, you get microcal inside. That's a very important feature that this is possibly a papillary thyroid cancer. Normally, it's not a rule for thyroid. In all malignancies, they tend to grow faster, so they are going to be taller than they are wide. So a taller lesion compared to a wide lesion is going to look more malignant. And if a swelling expand like this, and if it expands uniformly with time, the surrounding area tends to get compressed. And if it gets compressed, it develops a halo like the Indian gods they have behind. So if those halo is present, it is unlikely to be a malignant lesion. But if there is no halo with a sort of irregular acoustic shadowing, they are likely to be cancers. However, as I said, follicular neoplasms do not follow these rules in thyroid cancers, and therefore the yield in ultrasound may not be the best what you normally expect, and you might come out with surprises after surgery, as the gentleman who put the questions before you had this. So as I said, these are by and large the criteria, and now TIDADs have put in marks with everything, and you can calculate in marks and tell this is the score and likely to be benign or suspicious or hugely suspicious or clear-cut malignant lesion. So I would recommend that you use the TIDAD score in all of your patients, like we use the BIRADS in breast to characterize and categorize a thyroid lesion.
If I can just request Dr. Prashant Kumar Prusy to resend his question. His question is not really, it doesn't make sense. So perhaps he can rephrase that question and send it to the Healthium
Yeah.
Medicare chats. We have another question from Dr. Asit Chakraborty again, is that why is prophylactic supraumbilical neck dissection not done in thyroid malignancy with N0 nodes?
Okay, now, it is because number one, it has been proved beyond doubt that a thyroid cancer, I'm talking of differentiated thyroid cancer, I'm not talking about the anaplastic and the medullary thyroid cancer varieties. Most of the differentiated thyroid cancers, even if there is a micrometastasis, it does not alter the overall survival. This is number one. Number two, if you postoperatively do find few foci of metastasis in the neck, you can ablate it with wonderful and excellent results without much toxicity profile. So unless you do have a definite clinical or a radiological evidence of metastasis, you should not be offering the morbidity of neck dissection in thyroid cancer patients, which are as such a good disease. And if I am given the choice to get one cancer in life, I would always put my arms and in favor of a thyroid cancer. Most of my patients in whom I am operated, they feel I am a god because they are living for 15 years. But believe me, it's the molecular character of thyroid cancer which gives them this wonderful survival in most of the circumstances.
I take your example, Diptendra, but I will hope and pray that God gives you that. Now, we have Beyond also asking a little discussion on follow-up PSH monitoring, cutoff, and monitoring the thyroxine dose.
Okay. Yeah. As I said, if you go back to the presentation, I have given a clear-cut criteria in which I mean, if it's I normally prefer masses, though institute-wise it varies, but I normally prefer masses. And if it's a low-risk masses, you can choose to have just a physiological supplementation of thyroxine. If it's a moderate masses, you can choose to have supraphysiological dose of L-troxin. And if you have somebody with a really poor masses score, you can have these patients on supraphysiological dose. My only concern is because there is no evidence, a level 1 randomized trial to tell whether supraphysiological dose is really good or not. And in today's era, as you are going to use as such ablative therapies to a patient coming to a zero thyroid cell, the supraphysiological dose has its own problem. If this gentleman is suffering from a cardiac issue, a nagging tachycardia can be very nagging in terms of the cardiac comorbidity aggravating it, as well as quality of life. In some patients, they have come, the doc, I am really having all the features of toxicity. Would you like to reduce my dose? As I said, therefore, the complications of a supraphysiological dosage of L-troxin leading to a higher toxicity can be one of the reasons why we would not routinely use it. And second, as I said, with the advancement of radioablation, you don't really require that.
We have Dr. Somnath Ghosh. I don't know whether this is our very own Somnath Ghosh, who asks your follow-up experience in this type of cases.
Oh yeah, Dr. Ghosh, welcome Dr. Ghosh. He was the president and the chairman of the Association of Surgeons of India West Bengal State Chapter, as well as the governing council, esteemed governing council member. As I said, it's a common practice that I do not dare to come out with a pancreatic cancer survival in mobile phone in front of the patient. Most of the times, the statistics will not be the best that we like to show. But this is one cancer where I click it and show them, look at this. It's 98% 20-year survival. And therefore, as I said, differentiated thyroid cancers do have excellent results, even if the lady or the gentleman presents with extensive metastatic disease. Phase 1, we go on ablating, and they will come down to zero metastatic status in many of the circumstances. And most of them, even with metastatic thyroid cancer, if they do not de-differentiate, they are usually going to have excellent results with ablative therapy.
Dr. Prashant Kumar Trusti has rephrased his questions. He has two questions. Following total thyroidectomy for DTC, if the serum PT rises, what is the approach? I think you've addressed a bit, but I think it bears repetition. And he's also asked again, what is the surgical test? I think you've also made the point of careful surgery, but I just might be worthwhile to just go over it again, perhaps, Diptendra.
Okay, the second question, I missed the audio a bit. What was the second question?
Surgical steps to recognize the recurrent laryngeal nerve.
Okay, so I have discussed the second part. I will get back to you if you want me to do once again. Now, thyroglobulin. Now, if the patient is on L-troxin supplementation, something more than 5 a thyroglobulin level is which should give you a suspicion of possibly disease, something has come up somewhere. In today's era, you can, if the patient can afford, you can use the recombinant TRH and therefore suddenly make the patient use hypothyroid and choose to have an thyroglobulin done. The only one important word of caution that I would like to give to young residents is quite often, of course, not quite often, but rarely, patients might have anti-thyroglobulin antibodies or may have anti-TPO antibodies. And in them, if there had been an autodestruction of the thyroid tissue, a TG may not come up even if there is a recurrence. But if you have a TG elevation, you should go ahead with the next investigation as a radioiodine uptake scan after making the patient hypothyroid. And if you find evidences of you should be ablating. If it is, once again, I repeat, if the uptake scan is negative, you can choose to go for a PET-CT or a dedifferentiated form of thyroid cancer and start the treatment accordingly. The second question that was asked about recurrent laryngeal nerve, as I said, I divide it into basically 4 different parts. Number 1 is as it comes out of the thorax. Number 2 is at just close to the lower pole, the relationship between inferior thyroid and the recurrent laryngeal nerve in between, behind or above. Then number 3 is in the ischial group, and number 4, when it pierces, being covered by the Beri's ligament for some time, it pierces to get inside the larynx. So if you are careful in all those 4 parts and keep on having the habit of tracing the nerve right from the beginning, I am sure you are going to go down to 0 recurrent laryngeal injuries, except non-recurrent laryngeal nerves, which I have encountered thrice in my life, and I must confess once, without understanding, I transected it, and I noticed it only after the surgery that there is a grass hoarseness. So a non-recurrent laryngeal nerve can be really a troublesome thing, or else it's fine to dissect in all cases.
Thank you, Diptendra. Now, I'm waiting for some other questions, but can I ask a question that has been bothering me? About molecular therapy and the way that all these tumors escape. And, you're reminded of Siddhartha Mukherjee's book, The Emperor of All Maladies. It seems to find its way out of everything. And you've talked of the escape therapy and saying that the mTOR last that has come in is a wonderful experience. So why don't we use that as a first-line therapy, if that is so wonderful? And expenses aside.
Yeah, it's very, I mean, I have, in today's era, I look at chemotherapies as an extremely non-specific form of treatment. And gradually, as precision medicine is taking over, we would, I am sure, if we meet once again in a webinar in 2025, we might change our initial plan of treatment. Right? And in precision medicine, we would be able to predict at the beginning that this is a differentiated thyroid cancer with a 45% red proto-oncogene, red gene mutation, with a BRAF mutation of 30%, with the mTOR pathway is mutated. And therefore, right at the beginning, we'll be able to predict whether this gentleman is going to do well with radioiodine uptake scan. And therefore, we can go away with all forms of empirical therapy.
I have another question. We're talking of toxic thyroid nodules, and it seems to me that the pendulum, and I quite rightly, I mean, I'm just pointing it up because you're talking of using biologics for treating thyroid cancers. And I'm just wondering, for the toxic thyroid nodules, has the pendulum swung away completely from surgery into medical or nuclear ablation? What do you think?
Yeah.
Is there a scope for surgeons, or have we lost another?
No, we haven't. We haven't actually. And one of my favorite topic is the role of surgeons redefined. Now, I would not state that we are the first liners in toxic disease. The nuclear physicians, initially there was this issues with, with carcinogenesis and starting at the young age, whether you should be offering or not. But those fears have gone away, except if the lady is not pregnant or not breastfeeding. The role of surgeon in the first line doesn't come. However, at the same time, I must state that in patients who have developed a sort of secondary, in the traditional sense, secondary thyrotoxicosis, that means they were having goiter and suddenly one of the nodules have turned autonomous. It is far more easy to treat with surgery. And therefore, there is no harm in treating these secondary and the tertiary nodules with surgery, which can give them a clear-cut treatment right at the beginning. But as I said, the traditional grapes, we should not be discussing this because it has gone into the domain mostly of the nuclear physicians.
But I suppose if you have a lady who comes in with a toxic thyroid nodule and she's very worried about her cosmesis.
Well, of course, I would do that. The only issue is it can bleed really bad, and it's a very. I am really afraid to operate on a toxic goiter, even after they are made completely euthyroid. And I'm not that bothered about operating on thyroid cancer because unless they are completely fixed, they are a surgeon-friendly tumor. But a toxic goiter can be very oozy, can be very bleedy, and therefore that's one of the reasons. But yes, if somebody is cosmetically bothered, it gives us once again the scope to put our shoes in.
I wonder whether the Healthium chaps have any more questions, because I seem to have gone through most of mine. Perhaps the Healthium chaps, are they with you there? They're with you?
Yeah, they are with me. I know there is no more questions, so we can go to the conclusive remarks and discussions.
So, final take-home message, Diptendra. You're the best person to deliver that best take-home message.
As I said, the take-home message is there are wonderful things happening in thyroid cancer. It starts from the TIDADS, which is a very structured way of looking at the thyroid swellings and assessing it radiologically. All postgraduates must closely abide by the TIDADS methodology and categorizing a cancer or a thyroid lesion in that way. Every postgraduate must know of the Bethesda classification because that's how we are going to categorize thyroid lesions. Number three, most of us, we as of now have got a little access with molecular signatures, except in big metro cities. But I must assure you, the future of diagnosis will be on molecular signatures, not only in terms of prognosis, but in terms of predicting what form of therapy is going to be utilized. And that's what you were suggesting. And no ways you should be doing a thyroid surgery without observing the nerves, both the superior and the inferior ones, unless it's a really bad, nasty thyroid where you are unable to do so. The one extra addition I would ask, or rather explain here, of minimal access surgery and robotic thyroidectomies that have come up. And there is a group uh, from India who propagates doing a bilateral approach. And one of my very close friend who really does a wonderful lateral approach thyroidectomy from Kochi. That's a wonderful technique. But yes, they do it well. And I personally is still a traditional person going into the central route. And the minimal access techniques are also a welcome technique, and those who have started doing it, we are planning to start it here as well, either through the oral approach or you can go to the axillary approach. They are possibly one of the things that we are going to see much more in future as well.
Don't you have tumorous deposits? We used to be worried about tumorous deposits doing cancer surgery in the abdomen at one point in time.
I think that have not conclusive, I would state, but there are adequate evidences to state now that if you are very careful in retrieving the specimens in a proper way, the seedlings at the sites of taking out is not a major issue. But you should not really drag it, push it, break it if it's a malignant lesion anywhere, be it a gallbladder cancer or a thyroid cancer, wherever you do that, or else statistically the incidence is not tremendously high, and it is worth that those who have started doing it, and we should all be also trying with um, minimal access thyroidectomies as our future way of going ahead.
As much as that is it, and you think that might
Yeah.
replace traditional surgery as we know it? No.
I won't tell at this moment. I won't put my statement so strong and bold. In mid 90s, we all argued, and as I said in my last slide, the rule of the life is to change, and we must adapt to the newer technologies. And time only will be there with evidences coming out whether that was worth trying. We are trying this webinar, and I'm sure if it works out in all the webinars with both audio and visual, we are going to ASICons with webinar ASICons. So
Right.
it's a humble start, and I'm sure it's giving a good amount of scope to minimal access is to go ahead in future.
We have another question, Diptendra, from Dr. S.R. Rengan. For nodular goiter following hemithyroidectomy for lesions confined to only one lobe, do you need thyroxine treatment at suppressive doses? He doesn't mention about the histology.
Okay, so number one is if preoperatively you're very sure that the nodule is restricted to one of the lobes, then you are justified in doing a hemithyroidectomy. But if you find a nodule on the other side, do not be conservative. If it's a small nodule, you take it out because that helps, spares the person of another surgery in future. Number two is if the patient has got a destructive antibody positive, in the long run, there is a significant possibility that they might go into a hypothyroid state. But routinely, you should be doing a check of TSH after 3 weeks, after 6 months, and if the patient remains more or less okay, the possibility of going into hypothyroid state is not to that extent. Of course, they can develop hypothyroidism any point of time, but doing hemithyroidectomies will not lead to hypothyroidism unless they have the destructive antibodies in their body.
If by chance this nodule was a papillary carcinoma?
As I said, it's written on the walls. There are adequate evidences now to suggest that less than 1 centimeter, you are justified to continue with conservative thyroidectomies. But if the size is more than 1 centimeter, you should abstain from trying to do a conservative surgery. It does not help. It has to be done, except a small subset of patients of follicular neoplasms, which are called minimally invasive follicular neoplasms, where there is either a small area of capsular invasion without vascular invasion or vascular invasion without capsular invasion, and the size is reasonably low, and the patient would not like a second surgery. In them, it might be worth trying with a conservative technique, but by and large, as I said, it's written on the walls that more than 1 centimeter deserve a total thyroidectomy.
There's one other element, and I'm just being a devil's advocate out here. You know, having had youngsters trading under me, you often hear weird things. So there was something called the fine needle non-aspiration. See what? I never hear about it now. The Italians were trying that.
I have also not heard it of late, but we did have chapters in recent advances on non-aspiration cytologies, and but however, my cytopathological friends do continue to have the standard aspiration cytologies in most circumstances.
And I don't think there are any other questions. In which case, I would just left with one thing to say, a lot of things to say actually. I would like to thank Professor Diptendra Sarkar, and I'm glad Dr. Diptendra Sarkar agreed to this. That was wonderful a lesson on how to carry out a webinar on a very important topic. And I think the last slide was so valuable because they always say that the only constant in life is change. So I think your last slide was just fabulous. But I would also like to thank and owe gratitude to Healthium Medtech, who has made this exercise possible. And I will also like to give thanks to our past ASI presidents. You know, a cumulative work has gone through, a large amount of work has gone behind the scenes in setting up this sort of exercise so that we can reach younger surgeons all across the country. And I think that's the most important thing.
Wonderful. Yeah, exactly.
If you have anything else to thank, and then I will end by talking about the next webinar that is coming along.
Please. I will just extend my thanks once again to the office bearers, Dr. Raghuram, all the past presidents. This is a wonderful endeavor. And our co-partner for ASI, Healthium, they have really made a wonderful gift to all the surgeons, the young surgeons, reaching to every corner. And I'm told this software is so good that even if you have a 2G connection, you'd be able to go through that. So that's one of the biggest things that ASI have done in terms of academic improvement. And my heartfelt thanks. I really take a bow also to the office bearers for arranging this thing wonderfully.
Thank you. And I thank all the office bearers along with you, and the past and the present presidents also. Everyone has contributed richly to the association. Just to remind everybody, we started off with 221 members. In 1938, we had 19,000 plus. So be aware of your future for the next generation. You know, I've gone through a lot of years, and Diptendra is right in the middle. And I think we depend on the youngsters to take the torch forward, isn't it, Diptendra?
Yeah, exactly.
I would like to talk about our next webinar, which is dated the 29th of February, 2020. And the topic is going to be Approach to Rectal Cancers and Recent Advances. The speaker is Professor Somasekar, SP, Chairman and Head of Department of Surgical Oncology at the MHEPL, Consultant Surgical Oncologist and Robotic Surgeon, HIPEC Super Specialist at the Manipal Comprehensive Cancer Center. So, young members, young surgeons, please do remember to check into this webinar. Healthium is going to set up that meeting as well. And I extend my thanks to Healthium once again and to the ASI for allowing us this brilliant opportunity. And how can I not mention Diptendra Sarkar again, Professor Diptendra Sarkar for you.
Right.
Bye. Bye.